Thank you for the introduction and for having me. So I will speak about MR imaging of uveal melanomas and of ocular vascular lesions. These are my disclosures. MRI of the eye is difficult, and also because of that, until a few years ago, MR images of the eye had low quality. But recently, high-resolution MRI eye protocols have been developed, and with MRI, we acquire now very beautiful images of the eye. Uveal melanomas have been extensively evaluated with MRI. Ocular vascular tumors have not. I will start showing you the MRI protocol that we use to evaluate ocular lesions. The eye has small structures, so we need high resolution. We use a 3 Tesla MRI. We use a small coil that we put above the eye. We ask the patients to close their eyes and to try to minimize their eye movements, and we make several sequences because they give different useful information. So let's look at these sequences. We do T2 sequences because they have a very high resolution, and so they are the best for lesion characterization. So I'm speaking about diagnosis, differential diagnosis, but they are also the best to evaluate the local extension of a tumor. Very important for the T-staging and for treatment planning. And here we do T1 sequences before and after contrast, and we also perform T2 sequences. For instance, here you have an intraocular lesion. If you compare the contrast sequences with the pre-contrast sequences, you see what enhances is the tumor, what does not enhance is the retinal detachment. You also can see, this is a little bit a thick pointer, but the inner layer, white, is like the choroid and the retina enhancement, and the outer layer, more black, is the sclera that is not, sclera here that is not enhancing. Before contrast, you see the choroid slightly hyper intense, so slightly white, and the choroid, the sclera that is like hypo intense, so more black. We also perform 3D sequences, and why? Because they allow retrospective reformatting in all directions, which is very important to do accurate measurements. And you see here the multiplanar reconstructions of one lesion to be able to make an accurate measurement of the tumor prominence, here also involving the sclera. But we can also do 3D reconstructions which give information about the tumor geometry, and both are very important for treatment planning. And finally, we also do functional sequences, and the functional sequences are diffusion and perfusion weighted imaging. Diffusion says something about the movement of the free water in a mass, in a lesion. Perfusion will give you information about the vascularization of a mass. With diffusion, we can measure that diffusion value in the ADC image, and with perfusion, we get a curve where you can have an impression of the wash-in and wash-out of contrast in the mass, and you can also measure several perfusion parameters like the time to peak, the peak intensity, so saying something about how much the tumor enhances, and the degree of washout. And both these functional sequences are very important for us for the differential diagnosis, in particular to be able to say if a lesion looks benign or if it looks malignant, but we also use them now, especially after proton beam therapy, in the early follow-up after therapy to see if the tumor is responding or not, and we hope that they will also give prognostic information. Moving now to uveal melanoma. So uveal melanoma arises most frequently from the choroid, followed by the ciliary body, and in a small percentage from the iris, and they can have different configurations. Here you have an example of a dome configuration, here of a mushroom configuration, and here on to these images you see very flat tumors, so very thin tumors, one arising from the choroid, the other one there arising from the iris, both very thin, but with high resolution images, we can see them on MRI. The amount of pigment in a uveal melanoma is variable. And it is actually important to look at it because we know that pigmented tumors are associated with a poor prognosis. MRI has the advantage that we can look at the whole tumor, while with fundoscopy we can only evaluate the superficial ventral part of the tumor, being non-representative in case of a heterogeneous tumor. In our study, we saw that the signal intensity on one of the sequences we performed, the T1 sequences, this sequence, correlates significantly with tumor pigmentation. And here you have a good example. So if you look here at the T1, all this is a mass, is a uveal melanoma, but it has two different components. An anterior component, very like white, and if you look at the corresponding histopathological image with pigment, with melanin, and a posterior component, which is not white, is like grayish, and in the corresponding histopathological image without melanin. On diffusion, uveal melanomas characteristically have what we call in radiology diffusion restriction. How do we evaluate that? So with diffusion we get two images, a diffusion image and an ADC, and if a tumor has diffusion restriction, like melanomas, they will be very bright on the diffusion image and then they will turn black on the ADC image. But with diffusion we can also, as I already said, measure the diffusion value, the ADC value, and we know that for uveal melanoma the ADC value is 1.1. Why is this important? Because again, so diffusion will help us to see if the mass is suspicious to be benign, which has a much higher diffusion value than malignant, which has usually, like melanomas, a lower ADC value. On perfusion, uveal melanomas, 2/3 of the uveal melanomas will have this kind of curve, which is a washout curve, quick wash-in with washout, and 1/3 will have this kind of curve, which is quick wash-in and then a plateau. So we call this a plateau curve. We can also measure the perfusion values, as I already told you, and for instance, regarding the peak intensity, we know that the mean peak intensity is 1.6. So perfusion also is very important, like diffusion, to tell the radiologist this is suspicious for a benign lesion or suspicious for a malignant lesion, because, for instance, benign lesions tend to have a curve that is a progressive curve. We also use perfusion to assess the early response of tumor to radiotherapy, special proton beam radiotherapy, and we hope that it can say something that it will be able to detect high-risk uveal melanomas. Local extension, MRI is good to evaluate ciliary body involvement, extrascleral extension and optic nerve invasion, but it is not good to evaluate scleral invasion. Two examples. So here you have an example, a very small intraocular tumor. You see it in all sequences, so T1 after contrast T2. But if you look outside the eye, here pointed by the red arrow, you also see a small lesion exactly with the same color as the intraocular tumor, and that is extrascleral extension. In this case, it had already been noticed on the ultrasound, and it was proven to be true after enucleation. This other example is also a very flat tumor, intraocular flat tumor, but on T2, if you look at the red arrow, you will see that there is, or I'm not sure if you'll see, it's a very subtle, but you see signs of postlaminar invasion of the optic nerve, which was proven to be true after enucleation. Retinal detachment, we see it often, and it is more prevalent in larger tumors. What is important is to be able to differentiate the tumor from the retinal detachment. So if you look here, the tumor enhances, the retinal detachment does not enhance. The tumor has diffusion restriction, the retinal detachment has no diffusion restriction, and usually retinal detachment is like more thin, having more a lentiform aspect, like in this case. Vascular ocular tumors. So in radiology, for the classification of vascular lesions, we use mostly the International Society for Study of Vascular Anomalies classification, which basically divides these vascular lesions in two big groups. One are vascular tumors, the other one vascular malformations, but today here I will use the classification used by ophthalmologists, which divides these lesions in choroidal hemangioma, and then we have several retinal vascular lesions. Most of these lesions, most of the times, they are just diagnosed by ophthalmologists, and we, as radiologists, we are not asked to make an MRI of these cases. But choroidal hemangiomas have been evaluated with MRI, so we know how they look. Retinal capillary hemangiomas, there are some cases published especially about hemangioblastomas of the optic nerve, but the images, the MR images have low resolution, and there is only one article that I found with functional imaging, and all the other ones there are no image with MRI known. Choroidal hemangioma, so we have two different forms. One is the circumscribed form, and we have also diffuse form in the context of Sturge-Weber syndrome. On they are reddish-orange, they are more frequent in the posterior hemisphere, and they can have retinal detachment. On ultrasound, they are hyperechogenic, and in the indocyanine green angiography, we see that the lesion is, there is intense washing of contrast, and then there is also washout. On MRI, how do they look? On T2, they are very hyperintense, so hyperintense that above the lesion we see a hypointense line that I think it corresponds to the normal retina. On ADC, they have a very high ADC. You see here an ADC of 2.1. The mean ADC of uveal melanomas is 1.1, so this is very high, pointing to the benign etiology of the lesion. On angiography, you see, on the perfusion, you see the same configuration curve that we found in uveal melanoma and washout curve, but there is a peak intensity of 6, so much higher than a uveal melanoma because these are vascular lesions, so they enhance a lot. Retinal capillary hemangiomas, they exist frequently in the context of von Lippen-Lindau disease, but they can also occur isolated. They are described in the retina, but also in the optic nerve. When intraocular, they are most frequent temporal. So clinically, you see these dilated and tortuous retinal vessels, and in angiography, you see also wash-in and wash-out of contrast. I do not have an image of a retinal capillary hemangioma, and they are also not available. They have not still been studied with MRI, but we see them in the orbit, and you have here an example of a capillary hemangioma involving the lacrimal gland in a child. And what we see in these lesions on MRI is they enhance a lot. They have these like hypointense lines inside the lesion corresponding to vessels, which is consistent with what you see in the fundoscopy. On ADC, they have a high ADC, showing that it is a benign lesion and not a malignant lesion. And again, the perfusion shows, like the choroidal hemangioma, a washout curve with a high peak intensity. Retinal cavernous hemangiomas, they are usually sporadic, but they can be hereditary. Clinically, you see they have this bunch of grapes aspect on fundoscopy, but also on fluorescent angiography. And you see in the angiography that in the early stages they are hypofluorescent, but in the late stages there is going to be some pooling of contrast in the upper aspect of each grape. And again, I don't have a case of a cavernous hemangioma of the retina, and they are also not yet studied, but we see them in the orbit frequently. And this is the aspect of a cavernous hemangioma in the orbit, with on perfusion a slow enhancement, which is completely consistent with the fluorescent angiography, so this progressive curve, and also with a very high ADC, again because they are a benign lesion. Finally, retinal AVMs, they can be part of the Weber-Mason syndrome, where we can have vascular malformations at any point of the visual system. On image, again, I'm showing you, I don't think we are going to be able to see AVMs of the retina because it's about very small vessels. In the orbit, we see them, and then what we have, we don't see a mass, but we just see dilated tortuous vessels. And that is what we see on the anatomical images. Here on T2, you see all these flow voids. These are all very dilated vessels, and also in the MR angiography. In conclusion, uveal melanomas are well studied with MRI. We know how they look. They are few hyper on T2, they have a low ADC typical for a malignant lesion, they will have a washout curve or a plateau curve. Choroidal hemangiomas are already good evaluated with MRI, and they look different from the uveal melanoma. The T2 is much more hyperintense. The ADC have a much higher ADC because they are a benign lesion, and although the curve has the same type of configuration that we can have on a uveal melanoma, the peak intensity is much higher because they are vascular lesions, because they have intense enhancement. The retinal vascular lesions, we still need to evaluate them on MRI to be able to say something about them, but they are well known in the orbit, so I expect that they are thick enough, they will have the same characteristics on MRI if they arise in the retina. The cavernous hemangioma has a very high ADC, again because it's a benign lesion, and will show this progressive type of enhancement that we never see in a non-treated uveal melanoma. Finally, the AV malformations, they are very different because we don't see a mass, you just see enlarged vessels, so that is like not to confuse with a uveal melanoma. And I thank you for your attention, and I also thank my team, especially the physicist I work with, Jan Willem Beenakker.
Thank you so much. I think due to time we need to move on, so we'll take questions later on.